ഇപ്പോൾ കൂടുതൽ രണ്ടായിട്ട് കാണുന്നു, കുറയുന്നു എന്ന് പറയണം. ഇപ്പോൾ കുറഞ്ഞു.
When I'm turning head to the right and left,
കുറഞ്ഞു. ഇനി
turning the head to the right side is less.
കണ്ടുകൊണ്ടിരിക്കണേ. കൂടുന്നെങ്കിൽ പറയണം.
Turning to the left side it is more.
രണ്ടായിട്ട് കാണുന്നു.
Now you're saying double now.
ഇപ്പോൾ കൂടുതൽ രണ്ടായിട്ട് കാണുന്നു. ഇപ്പോൾ വളരെ കൂടുതൽ രണ്ടായി. കണ്ണടയ്ക്കാതെ ഇങ്ങനെ തിരിച്ചേ. ഇപ്പൊ അത് കുറഞ്ഞോ?
ചെറുതാണ്, പക്ഷെ രണ്ടാണ്.
That's the story. So what is the diagnosis? I will show this is the diplopia, is combined diplopia and looking down. This is the position of the eyes. Let us analyze one by one. What do you think the problem could be now? The complaints of vertical diplopia.
The right inferior oblique problem or left inferior rectus problem.
Okay, but we cannot be certain. No, his left eye is down. That means, and his diplopia is only looking down, not looking up. So the problem is
left eye is up and right eye is down, sir.
Correct. What I said is correct. But diplopia is looking down. So which eye should have been at fault?
Left eye.
Left eye.
Yeah. If right eye had been at fault, if the elevators were depressed, the diplopia should have been on looking up. Here diplopia is looking down. So it must be right. Means that which all muscles could be weak on the left side to produce diplopia and looking down?
Left inferior rectus or left superior oblique?
Very good. That's the answer. So means it could be left inferior rectus, left superior oblique. Now the next question is which muscle is at fault? Is it superior oblique or left inferior rectus? What test will you do?
Superior oblique.
Sir, Bielchowski's head rotation.
Okay, right. Let us see now. This is the head rotation I did.
ചിരിക്കുമ്പം കൂടിയോ കുറയെന്ന് പറയണേ. കൂടിയോ പറയണം.
He says that diplopia is less on turning to the right side, rotating to the right side.
ഇനി നോക്കിക്കോ. വലുതായി. രണ്ടായി.
It has become more.
രണ്ടായി. മിനിറ്റ്. ഇപ്പൊ രണ്ടായോ?
So it's more on rotating the head to the left side, less on rotating to the right side. So is it which is
superior oblique problem?
Okay, left superior. Now, how do you approach that diagnosis? That's a point I would like to make here. See, here diplopia is more on rotating head to the left side. This positivity and head rotation does not always mean superior oblique muscle. It can also occur with the rectus. Because vertical and inferior recti also are rotators also. So that also can produce a tilt to the image and rotating the head to the right and left side. Here the person has got diplopia more on rotating the head to the left side. Say my left side is like this. So that means on rotating to the left side, the eye rotation is indoors on the left side, right eye is extorting, correct? The side in which eye head turns, that eye will intort. The opposite eye will extort. So weakness of any of these muscles can produce this diplopia, worsening on that level. So it could be a problem with the intortus on the left side or extortus on the right side. Or any of these muscles can produce worsening on tilting the head to the left side. So on rotating head to the left side, left eye goes in intorsion, right eye goes into extorsion. So worsening of diplopia is due to one of the intortus of the left eye or one of the extortus of the left eye at fault. That much is can guess from here. Now you have to analyze further. That means it used to be a left superior oblique or a left superior rectus, which are the inverters, or a right inferior rectus or right inferior oblique, they are the extorters. So this much is the problem from that. Now, in our patient, from the beginning, we saw that there are two muscles only at fault. It could be either left inferior rectus or left superior oblique, right? Because his left eye is up on looking down, that means left inferior rectus or left superior oblique could be weak. This test tells you that it is not an inferior rectus, but a superior oblique because superior oblique is an intorter and the left inferior rectus is not an intorter, it's an extorter. So if you turn to the rotation, one of the intorters should be weak. So our muscle in question is inferior rectus and inferior oblique, superior oblique. So that means it is not inferior rectus, the culprit is a superior oblique causing that thing. Okay, so you must understand this problem now. Is it clear to you? how this head rotation can be useful to select out which are the muscles. Okay. So we're utilizing the intorsion action of the muscles and extorsion of the action of the muscles. Intorsion action in which direction the head is rotating, extortation in which direction the head is opposite to the rotation. The extortation will be acting. Now let us see. So what test you want? What is the cause of this? Now we know a superior oblique palsy. What test you need to know? Most likely it's a post-traumatic one, but it occurred 1 week later. He did not notice immediately.
Force reduction.
Okay, but why post-action? Post-action only for a restrictive ophthalmopathy. But is it correct? If the fracture of the orbit and the muscle get caught, you can do that. Agreed with that.
Because it was after 1 week, some swelling or as a fracture or anything that could.
Well, that should have occurred immediately also, no? Anyway, or it's possibly that he may have noticed later on. He may have having pain and all, he may not be opening the eyes properly, he may not be walking about. When he started walking about, he might have noticed a diploma. That's the usual situation. So as you said correctly, it would have been there in the very beginning, but he noticed later on. That more likely so. Or I agree with you, it could be restrictive ophthalmopathy, or it could be a weakness of the superior oblique. So what investigation will you do? You can do the MRI, no? To find out whether it's any fracture or anything in that and the orbit and all. Okay, this orbital MRI, I said the brain MRI also can be lesion in the brainstem also. We do not know. Just take it to be brainstem because only superior oblique is affected. Other no long track signs. Anyway, let's see the brain MRI. This is the T2 weighted. No obvious brain lesion seen. This is the coronal cut. There is some lesion which could be seen on the left side. I'll come to that later on. This sagittal cut, it's not very contributing. This is the SWA to find any hemorrhage where in the brainstem and all. There is no hemorrhage in the brainstem or anywhere. To account for the superior oblique, that is not there. This again is that initial was GRE, this is a gradient, sorry, SWI. This is a cis sequence. Look carefully at the cis sequence. There is something you can see in the left orbit. There is something occurring in the posterior part of the orbit. It is abutting the optic nerve. That arrow is pointing to that vertical area. I saw the screenshot later. That is the upper part. So the MRI of the orbit, again take a close look. You can find out that lesion there.
Immediately following trauma and super 2 weeks that is the thing which very trauma.
This is again the still sequence when orbital lesion. You can see a small hyperplus lesion in the orbit. See that one? The middle of the orbit posterior, in the posterior part. I'll show that video once again. That's the This is the T1. Again, you can see the hypotenuse lesion there, adjoining the optic nerve there. So what did you find? There is a hypointense lesion in the orbit in T1. Still sequence is hyperintense. And C sequence shows the hypointense lesion there. So there is some lesion. We do not know what the nature of it. So what will you do now?
CT,
Pardon?
CT brain.
CT brain, but CT brain for what? There is already we found a lesion there now. It's all not occurs. Pardon? Contrast was done. That lesion was not contrast. In fact, I forgot to show that thing. There was not showing much of a contrast in that aspect.
Is it a vessel, sir?
It could be. It could be a vessel. My question is, so what will you do now? It could be a vessel. It could be neuroma, or it could be something else.
It's unlikely to be responsible for the symptom.
Why do you say so?
From the superior aspect, no?
Correct. So that's the answer I wanted from you. See, if you find some lesion there, does not think that it is responsible. You have to think logically whether whatever be the lesion, is it responsible for the present symptom of the patient? It may be incidental finding which has been there earlier, we do not know. So this is not in the position to cause compression of the superior oblique nerve, nor in the region of the muscle at all. So that lesion cannot cause superior oblique palsy. That's the first thing. So that's the location. It is most posteriorly that location. So what do you like to do, surgery? It's the least responsible for the superior oblique palsy. So what do you like to do now? Now see this sequence MRI very closely. I will show the C sequence. Can you find out some abnormality here? We took a thin cut of the C sequence. Did you find anything there? Exactly in the region of the trochlear nucleus. Okay, that is trochlear nucleus. So after exiting from that area, the trochlear now from the trochlear nucleus, it goes posteriorly and crosses the superior medullary lesion and crosses the opposite side. So this is on the right side of the midbrain. Our weakness is on the left side. They're exactly because, as you know, the superior oblique supply, superior trochlear nucleus supply the contralateral superior oblique muscle. So did you see the hyperdensity there? And exactly in the region of the superior colliculus or exit from that superior nucleus. Whether the nucleus from the exiting nerve, we do not know. But the point, remember, is that lesion can explain the contralateral superior oblique muscle. That is the reason why I bought this case. There can be some red herring somewhere in the MRI, but always try to think that whether that lesion is responsible for the deficit or not. So that's the answer. He has got a superior oblique nuclear involvement causing the palsy.
Why is he having a diplopia on turning the head to the right? He's still having a diplopia, no?
No, he said he's less, much less. Sometimes he's less, sometimes it's mildly present.
Shouldn't it be completely absent or it can be present?
It can be present. After all, there is a disconjugation which matters, which is less on retained on the other side, maximum on retained on the left side. Always there is a disconjugation, all the time it's present. The question is, it is much become less or more.
So in such cases, how do we say that the left inferior rectus is not involved? Can we say it's partly involved?
No, because see, left inferior rectus can be involved, but in that case, the diplopia should have been more on turning the head to the other side.
No, this patient may be having a left superior oblique more weakness when compared to right, left inferior rectus, which is having.
Yes, that is possible. That is possible. That possibility can be ruled out. Then we have to implicate two nerves now. Okay, so partial third nerve and superior fourth nerve. The commonest cranial nerve affect in post-trauma is fourth nerve.
Why
But
the symptoms
that's usually because the involvement of the superior
later?
oblique nerve, no? Not because of brainstem involvement.
Not because of brainstem, because of the nerve is involved.
But here it's a brain involved.
Yeah, it's a brain involved. That's a funny thing. Because we found that usually we don't find any lesion post-traumatic trochlear nerve palsy at all. Sometimes the lesion may be in the trochlea itself, the orbital injury. Lesion may be in the trochlea. There may be local tenderness there. But this case had a focal injury to the brainstem. That is the interesting part of this case.
It's not an old infarct, no, it's a injury, yeah?
Maybe. So that's a very unusual site for an infarct there.
Why the delay in presentation? Because patient did not notice initially or it appeared later?
No, most likely he did not notice initially. That very often happens, no? When you have an injury, he may not be able to walk, maybe taking rest. Then when he started walking, when he climbing downstairs, he started noticing these things. That's very common. That sort of study. But this is the history he obtained. Whatever he told, I am telling it, presenting in that way. You have the substitute to decide how to reorganize or manipulate the history in your favor.
Would you again re-image him for after a few months to see what happens?
Yeah, right. That's our idea. I told him we need repeat MRI after 2 to 3 months with a contrast study again, whether there is a neuroma or anything unrelated is increasing or not. That you have to do. Because we still do not know what the lesion is. Radiologist has opinion that it's kind of a neuroma sitting there. Okay, shall I go to the next case?
Sir, can the radiologist
Yes, sir.
say
Yes,
that
sir.
if this lesion is intracornal, extracornal or something, sir?
It is intracornal lesion.
Okay, sir.
Because of the axis in the coronal cut, it is in the intracornal location. It's just behind the globe.
Okay, sir.
Shall I go to the next case? Okay.
Yes, sir.
Yeah. It's a 56-year-old female. Yeah. She's a known case of diabetes and hypertensive. Noticed loosening of the chapels on the left foot 8 weeks for the last 8 weeks. This is a long case. 2 weeks later, she noticed one episode of buckling of the left knee, followed few hours later by facial elevation on the right, and mild dysarthria and clumsiness of the left hand. These latter two symptoms, that's the weakness of the left side and everything, except the knee weakness, improved over a period of 2 weeks. For the last 4 weeks prior to admission, patient noticed difficulty in walking, urinary incontinence, which progressed to total inability to walk in 2 weeks' time. So the complaint in the lower limb have been progressing, but in between, patient had one episode of facial elevation on the right side, dysarthria and clumsiness on the left hand, which apparently improved. This is exactly the story she told. So known case of diabetes, hypertensive. First, loosening of the chapters on the left foot, 8 weeks. 2 weeks later, patient noticed one episode of buckling on the left knee. Probably she must have worsened the left lower limb weakness. This is followed a few hours later by facial deviation on the right, mild dysarthria and clumsiness on the left hand. The latter two symptoms improved over a period of 2 weeks. For the last 4 weeks, prior to admission, patient noticed difficulty in walking, urinary incontinence with progress to total inability to walk in 2 weeks' time. So this is the video of the patient. Cranial nerve examination were normal. Come to the upper limb, tone was normal. For examination is bedridden stage, which also for examination not fully correct. It appears to be normal in them. You couldn't make out any obvious weakness. Hand grip is also normal. The lower limb, it was she was not able to get up from lying down position. There is hypotonia of the lower limb. There was mild wasting of the thigh. It's severe weakness of both lower limb, about grade 0 to 1 for the hip flexors, knee extensors. Dorsiflex is also grade 1 only. Plantar flexion was about 2 to 3. That she is able to do. Just 2 power is there in the plantar flexion. Come to the reflexes, upper limb reflexes normally elicited. The lower limb knee jerks were absent, just elicitable by reinforcement, but almost absent. Ankle jerks were anyway absent. He is diabetic for 13 years. Plantar was indefinite. Mute plantar. Sensation is able to feel pain all. She is able to feel, but not on the left elbow. There she is not able to feel. Right hand she is able to feel. Lower lip, it's absent. She says absent, the superior spine also it is absent. And for JP's examination was inconsistent. I couldn't get a proper answer. So that's not very reliable. SLR was negative. So IML function is normal, Taylor's normal. Motor tone power normal in the upper limb. Both lower limbs are flaccid. Power grade 1 in all the muscles except the plantar, as far as lower limb is concerned, except the plantar flexors, which are about grade 3. DTR abnormal in the upper limb. Lower limb knee jerks were absent. Ankle jerks were just elicitable. Plantar indefinite. Sensation touch pain normal in the upper limb and lower limb. Impaired vibration over both hands and left elbow. Impaired vibration in the left lower limb up to the iliac crest. JP sensation inconsistent, SLR negative. So this is the finding. Record the finding once again. Upper limb tone power normal except got a sensory loss in the left upper limb. In sensory, I think you cannot totally believe in the patient. It was very, very inconsistent. But what is definite is a flaccidity to the lower limb and 0 to 1 power. Upper limb normal power. DTR is normal in the upper limb. Both lower limb reflexes were absent. What is definite is got a sensory loss in the lower limb. The upper limb, she said vibration was absent in the left upper limb more than the right. So this is the story of the patient. So where do you think is the likely lesion in this patient? Site of lesion.
Abdominal reflexor.
Abdominal reflex patient, I didn't know it's quite large abdomen.
So what is
Pardon?
sensory examination or trunk normal, sir?
Sensory examination little inconsistent. She said she is not able to feel vibration, including the anterior iliac spine. Below also she is not able to feel. In the hand, right hand she is able to feel the vibration. Left hand she was not able to feel the vibration.
So, on the trunk?
Trunk, there is no primary pain sensory was normal.
Okay.
So in
There
the
is
history,
no. Pardon?
history only left-sided gradual weakness.
No. I'll tell the story once again. She initially noticed dragging of the left foot. Then the lower limb weakness actually gradually progressed to the state. In between, patient had dysarthria, facial deviation, left upper limb weakness. That improved. One is a period of left-sided hemiparesis, and that improved. But the lower limb weakness gradually progressed.
She
Looks
never
like
complained
a
of right leg weakness.
Pardon?
In the history, there is no right leg weakness.
In the history, right leg weakness is that because difficulty in walking has been there gradually progressing over a time.
Okay, sir. Okay, sir.
Both
Sir,
the lower
how's her
limbs.
bladder functions, bladder bubble?
But yeah, there is a history of incontinence of urine. She's on catheter.
Myeloradicular versus radicular neuropathy. So if the
Yeah.
predominant radicular neuropathy is there, but odd points is the bladder involvement and a vibration level up to the iliac crest, which suggests any myelopathy, sir. The one
Yeah,
symptom may
perfect.
be a TIA or a mild stroke, sir, which has improved, sir.
Very good. That's a thing I also thought of. Any other thinking?
Sir, plexopathy, sir, lumbosacral plexopathy.
No, the bladder is also affected, no? And you can't explain the sensory level up to iliac crest all through. Oh, we can explain theoretically, but very unlikely, no? Bladder is affected also.
Multiple lesions, one in the intracranial and one in the cord.
Yeah. If cord lesion mean you mean human paralysis or element paralysis?
Like UMN only, sir.
But how can you explain the absent reflexes, flaccidity, mute plantar?
Maybe in the spinal shock.
But he has got a plantar flexion power is about 3 is there.
Intramedullary, sir, in the spinal cord.
Yeah. Okay. That means where from where to where? What you said is correct. It could be lesion in the conus epiconus region going up to say D1 in the spinal cord. You can explain that thing. Upper limb weakness is due to the unrelated stroke. Yes, that's a possibility. Okay, so this is how to approach the basically element paraplegia. So that is correct. So whether it could be radical neuropathy, that is one common thing which you have to consider, because very unlikely it's confined to the lower limb alone, to such a degree to produce zero power without affecting the upper limb cord. And more importantly, the bladder involvement has already been mentioned. So that seems less likely. Now, extensive caudate lesion can produce lower limb weakness and bladder involvement, as absent reflexes. But in caudate per se, the hip flexor should not be affected, because that means the lesion has gone above the caudate, because cannot explain the flexion weakness. And of course, the sensory loss in the upper limb could not be explained, maybe part of the old stroke, we do not. But the right upper limb also vibrates. She said improvement, but that you cannot take into consideration. So then the other possibility, where can the caudate is meningeal pathology, implicating the caudate, which is spreading upward, implicate the not only the caudate roots, but also the thoracic roots also. Above L1, about detail, that also can explain, produce this kind of phenomenon, element paraplegia with bladder involvement. Radiculopathy not only confined to the caudate, but the lesion has gone up, like a meningeal pathology. Or, as already discussed, one possibility of LETM, extending from the lower spinal cord, extending upward. It can also produce exactly like an extensive caudate lesion. See, caudate lesion can be equated or equivalent to a conus epiconus lesion. If the lesion happens to extend upward, the trunk muscle also can involved. But not a lesion confined only to the caudate. Same thing can also occur. The caudate roots plus the associated roots around the coming from the dorsal cord. So which is which we cannot say from here. So these are the possibilities. Agree with me about these possibilities? The last two won't be more likely. Radical neuropathy, less likely. Okay, so what investigation you want?
Spine and nerve conduction.
Okay, conduction. So we do the conduction. First, I like to rule out the radical neuropathy is there. Let us see the conduction now. The median ulnar conductions were normal. Look at the peroneal, both peroneal amplitude is low. Tibial amplitude is normal, and the tibialis anterior is also normal. So only the distal part of the muscle is got a low amplitude. And the velocity is normal. And sensory potentials are all normal, even though she said diabetic is quite normal. And FA latency is also normal except for the one left tibial nerve, otherwise all normal. So what is your inference from the NCS?
Axonal pattern.
Yeah, it's an axonal involved. So that means the snap is normal and same amplitude is taken. So you have to think of a epiganglion at least. Lesion is likely to be in the cauda equina or above. So that's a site of, it may be cauda equina or maybe in the cord also. Because the anticonsal, both the cauda equina roots are coming from the anticonsals of the conus epiconus. The lesion is involved in the anticonsal, there also it could be the same low amplitude, but snap will be normal, just like in this patient. So this makes a radical neuropathy very unlikely because there is no evidence for demyelination except for the one FA prolongation, and the snaps are also normal. The motor conduction and the velocity is also normal. So demyelination is unlikely. So first possibility is out. So what else you need now?
MRI spine.
Okay, MRI spine. So MRI dorsal, sorry, lumbar spine. This is MR lumbar spine. Lower dorsal as well as the cauda equina. Again, you can include the lower dorsal cord also, including the lower upper cervical and upper cervical cord, the dorsal cord. This is another cut showing the conus epiconus region. And this is the axial cut, the cauda equina, detailed L1. Then just below that, this is L2, L3, L3, L4. Then below the level, this is the T1. It's the T1 weighted sequence. So MRI, T2, dorsal spine, lumbar spine, normal. What do you want now?
Contrast.
Contrast, okay.
Can it still be Aman,
MRI,
sir?
pardon?
Like, can it be Aman, sir? Like localized forms of Aman? This,
Yeah, but only okay, that can be a problem. What you said is correct. But only one nerve is affected. So tibial amplitude is normal. Only conperoral amplitude is low. We can say that the proximal conduction ephemeral was not done, but that's maybe the reason why it is not in there. That can argue on that. But again, bladder problem comes in, bladder involvement becomes a problem. And Aman confined produce zero power of both the lower limb with sparing in the upper limb.
Okay, sir. Okay, sir.
Yeah. But that's a good possibility where the sensory potential can be known. Okay, MRI brain was done because patient had a left hemiparesis like the in-between brood. He showed an acute infarct in the subacute infarct in the right coronary radiator. You can see that hypointensity in the ADC. This is a T2 weighted sequence. You can see other infarct occurring in the other areas also seen in the caudate nucleus on the right side. Then in the coronary radiator, and again on the right side. This is a T1 weighted sequence. If you have multiple infarct, one in the coronary radiator, another in the caudate region, the first one again in the recent one on the again coronary radiator.
Ischemic myelopathy as a cause for.
But the thing is gradually progressive. See, first combined was dragging of the foot on the left side, then develop progressive weakness of both the lower limb and con. That's not the presentation of a ischemic myelopathy.
Neural AV fistula.
Okay, that is possible. Very good. That can be sometimes dual AVP can be missed in MRI. But here, there's usually you may not find forward, and you take a specific sequence for that. Because sequence equivalent to the C sequence in the brain can be done where you can find forward. But here, no forward is seen, whatever is available, but that's a good possibility you have to keep in mind, which can present it like that. But then you have to think two etiology. One, infarct due to diabetes, hypertension. Another person you need a spinal angio. Agreed? That's correct.
Arachnoiditis.
Yeah, that's another possibility. Very good possibility. Right. So what do you want now? I showed you. That's the question.
Contrast MRI.
Okay. Contrast MRI. This is the contrast MRI.
There's some enhancement in the anterior part of the conus epiconus region.
Okay.
Multiple sites enhancement.
Multiple sites, very good. And this is a contrast. I'll come to that. The MRI, the brain is also done.
Meninges also.
Meninges, patchy enhancement is there, not very convincing. Some area there are enhancement. But what is striking is that what Joy has already told you. Said, look at the MRI once again. This is the left one is the plain one, the other one is the conda. Did you see the enhancement of the cauda roots as well as the epiconus region here? The roots are all enhancing, plus it has the enhancement is going up. It's leptometric enhancement like this. That could explain the element paraplegia, including the roots surrounding the dorsal roots also, which is coming down.
Anything in the cervical, sir? Anterior part of cervical.
Yeah. There is another lesion, the anterior part of cervical. Did you see that one? So it's got multiple areas of contrast enhancement. And so what is the possibility now?
Sarcoidosis.
Okay, sarcoidosis.
Carcinomatous.
Tuberculosis.
Yeah, common things are common, no? Tuberculosis. Yeah, that can also produce vasculopathy and then produce infarct also. Tuberculous meningitis is a possibility. So what else you need?
CSF study.
CSF. See, 200 cells, lymphocytic predominant, protein 439, sugar 106, this may be a wrong value anyway. CBNAT was negative, ACE level was 49. So what else you need?
HRCT chest.
Okay. CT scan was done normal. CT chest was done, which showed no hylar gland, but showed evidence of healed tuberculosis. Where is that? Sorry. I'll show the. You can see the scar in the posterior part of the. So, goes in the hospital. Then what happened? We put the patient antituberculous drugs and steroid. Patient developed progressive altered sensorium on the second day. And patient developed weakness of both upper limbs, left more than the right, as well as key deviation to the left side. So what might have happened?
TB vasculitis.
Or
Yeah,
hypertension.
another part. So repeat MRI showed this repeat. This repeat MRI. The infarct here in that area. That is the area of where the anterior coronal artery is there, supplying that area. That is
Why is he unconscious because of that?
I don't know. She can drowsy and unconscious. I do not know. It's happened long back. Already she is a compromised circulation on the other side. In fact, may have produced that. Whether it's shared hypotension, we do not know. This is the area of infarct. So this is the story. So most likely she must have having tuberculous meningitis with the vasculitis, producing arachnoiditis as well as vascular compromise.
Did she improve, sir?
No, I cannot answer because this case was 2 years back, and I did not have the follow-up for that patient. Okay, the idea of bringing the case is to diagnose when you get extensive element lesion like that. Not confine yourself to think of LETM, but also consider the possibility of longitudinally extensive arachnoiditis. This may be outside the spinal. Okay, any questions?
Sir, if patient had in radicular pain?
No radicular pain at all. There's no radical. See, these are all people say arachnoiditis but radicular pain. It need not be there at all. I've also seen many arachnoiditis without any radicular pain. They can produce a constrictive myelopathy, and they can produce constrictor cords all around and can produce this without any pain. They can present you with ischemic myelopathy, arachnoiditis.
Previous stroke could also be a vasculitis itself, sir.
Yeah, but if I would explain the arachnoiditis in this patient, spinal arachnoiditis.
No, sir, I'm telling that previous stroke itself could be TB vasculitis.
Yeah, maybe. What is it is correct. Maybe.
Yes, sir.
Yeah, that's perfect. That's the thing I also keep in mind.
So without the intracranial, the meninges being involved, can the vasculitis still occur?
Definitely it can occur because the tuberculous vasculopathy can involve the vessels alone can be affected. The usual causes, as you said, is quite the meningeal basal X-ray is constricting the vessels, but that need not be there to produce that.
Okay.
So one doubt, sir.
The sudden paralysis evolved over a period of 24 hours. Sir.
No.
Bilateral weakness.
No, weakness progressed over a period of time, 2 weeks time. Over a period of 2 weeks, she became paraplegic. See, initially also, she was having dragging on the feet. Okay, that was progressing. At that time, she had another episode left hemiplegia. So everything will concentrate on the left upper limb. That improved. But the lower limb weakness never improved. And over and above that, that weakness progressed over the next weeks to present paraplegia. At that time only she became incontinent. So the left lower limb weakness has been there 6 months or so. That is gradually progressing. In between, she had an acute event that improved. Somebody was asking some question, please.
Yes, sir. For arachnoiditis, TB arachnoiditis, how long we will give the ATT and also the steroids, sir?
No, that I find it difficult to answer that thing. So if you believe me, I have given treatment for 4 years. Steroid treatment for 4 years for an arachnoiditis patient. And that patient ultimately improved, quadriplegic improved after 4 years. Nobody will believe that. No, this patient was from Germany when I was came to Amrita Hospital where I was working. I don't think we'll knowing the case. His spinal cord was thick, means thick X-ray all around the spinal cord. You will not just believe that thing. From cervical region down to thick X-ray. And we tried everything, continued ITT for 1 or 2 years, but still he's paraplegic, but gradually improved. We continued with the steroid and gave methotrexate. Ultimately became everything subsided, started working. So we continued for 4 years in that patient. Now, anytime, tuberculoma can persist 1 or 2 years later, you stop everything, tuberculoma will remain there for years without worsening. I have treated, I can show you one case where I treated for 4 years with methotrexate. Give ITT for only 1 year. That patient never progressed, but tuberculoma is still there. Then ultimately I stopped methotrexate also, took an MRI again. Again, tuberculoma is persisting. That's not worsened. So tuberculosis is a very enigma. I do not know how these people behave.
Sir, that could be sarcod also, no, sir?
Which one?
This kind of arachnoiditis with which is
No,
responsive only
that's
to
a proof.
steroid.
No. Even this is a proved tuberculosis. These are all proved tuberculosis.
No, can sarcoid also present the same way, like this case that we just discussed, like arachnoiditis?
Usually sarcoid will present in arachnoiditis. They have a characteristic pattern. That is, they involve the pia and then involve the parenchyma and spinal cord, produce the trident synapse. Pure arachnoiditis alone sarcoid possible, but that is not the usual presentation of sarcoid. They involve parenchyma plus the leptomeninges.
In the active stage of tuberculosis, CB-NAT can be negative. Doesn't?
Yeah. CB-NAT, everything now. There is not a single test which can conclusively exclude or include tuberculous meningitis. All tests can be falsely positive or can be falsely negative.
One doubt. In tuberculous arachnoiditis like this, can cells be absent, sir? In a suspected case of CNS tuberculoma, if we do CSF, can CSF be acellular, ADA negative, and then also we can start ATT?
Certainly yes. Certainly yes. Because when tuberculous meningitis is one condition, it has always been overtreated as well as undertreated. We still do not know which patient. See, I'll tell you, I can, out of my experience, I'm telling. So, one child when I was in Kottayam was diagnosed with suspected tuberculous meningitis. Every test came as negative. Every time came. There was a fever, headache, and that's all. When a CSF normal, CSF should mild pyocytosis. All other tests, tuberculosis negative and PCR. So what the pediatrician did to us, they seeing the all test negative, stopped the anti-tuberculous drugs. We started anti-tuberculous empirically. You know what happened? 1 month later, came in a comatose state in hydrocephalus with total blindness. And that there is frank X-ray and hydrocephalus. So these things can happen. So that is why you have to sometimes overtreat. We cannot believe on any single test. The suspicion is high, you always treat. That is, it's always overtreated as well as undertreated. Because there is no single test by which conclusively say it is tuberculous meningitis. Or it's not a tuberculous meningitis.
So regarding the differentiating features of CNS tuberculoma and also, sir, neurocysticercosis, sir, how to differentiate, sir? Sometimes the lesions are big. So is there any cutoff value where we can say this could be neurocysticercosis or like that?
No.
20 size.
Well, there are many radiological features by which you can differentiate the two, apart from the size and inside the cysticerca inside the what do you call that thing, scolex inside that thing, and the appearance in the cystic nature of the lesion in the cyst sequence. Those things can help to differentiate the two in cysticercus and the tuberculosis. Sometimes it's difficult.
So cysticerca, so antigen can be tested, CSF.
Yeah, and CSF can be tested in the antigen. If it is present positive, you can.
So Kernigstein is positive in this case?
This particular lady, I do not
Yes.
remember. I don't think I have done that in this patient. We were always thinking in terms of a lower limb weakness called paraplegia. And I don't think I did look for this in appendix and an next difference in that patient. SLR I did, that was negative.
Sir, what made you do that MRI brain, sir?
Because he had got, but he had a left side hemiparesis which improved, no? That is why he did MRI.
Okay, sir.
The second episode were clear. Acute onset weakness, gaze policy has to be another impact. Okay, shall I go to the next case?
Sir? Sir, one doubt, sir. At what time we can introduce methotrexate, sir, as a steroid sparing?
Because this particular 2-3 patients I have started methotrexate because some people give thalidomide, some people methotrexate. No, because this particular patient who when I was in Tiruvalla had a multiple bunch of grapes in the brain. Initially, was symptomatic headache, but no focal deficit. So as usual, give anti-tuberculosis test, continued for 1.5 years. I continued ATT with steroid. Every time after 3 months, 6 months, I take MRI. That bunch of grapes sometimes will disappear, sometimes other bunch will appear on another side. It goes on coming like that. Some of them will go up, some of them will appear, even on treatment. Then after 2 years, then I thought better stop ATT. Why? What's the meaning of continuing ATT? Because it ultimately is immune-mediated reaction. So continued for steroid. How long can we give steroid for a patient? So I stopped steroid, substituted to methotrexate. Again, I started following up the patient for every 3 months MRI. But the lesions are remaining there. Some of them decreasing, but not gone. Then I fed up. I stopped methotrexate also. And then I thought, let me see what will happen to the patient. Again, 6 months later, he came back. He's asymptomatic, totally asymptomatic. But repeat MRI shows typical. Then again, after 6 months, again, then he stopped coming. So 4 years I have been keeping a follow-up. I do not know how to deal.
Okay, thank you.
Sir, what is your experience with post-tuberculous meningitis, arachnoiditis? What is your experience with intrathecal hyaluronidase?
No, usually Gauri Devi madam used to give that thing. I know I did only one patient while I was in Chandigarh. Otherwise, I had not given up. Because there is no consensus opinion as to give hyaluronidase. There is no proved data to find its efficacy.
Okay, thank you, sir.
Intrathecal steroid I have given. But nowadays in Kerala, you don't see much of a tuberculosis hyaluronidase at all. In North India, it's quite common. In Kerala, very, very uncommon.
So what about the treatment response between this tuberculosis and sarcoidosis with steroids? Is it? So can we?
And a steroid response, invariably sarcoid will improve with steroid. Some of them are very resistant. You can go for higher immunomodulated treatment. But most of the sarcoid which I have seen, I have not got much of experience with that. They do improve very well with steroid. Only 2 cases, and invariably that patient has to be put on some immune modulated drugs. 2 of my patients, also that I can present the case next week on Imuran, Satyapan for a long period of time. And both of them are quite stable, well controlled.
So how long do you give steroids in sarcoidosis, sir?
No, not, that can be substituted by other immunomodulated drugs. We give steroid along with immunosuppressant or mycophenolate and gradually taper off the steroid and stop over a period of 2-3 months' time. And the other immunomodulator, mycophenolate, is being continued. That I never dared to stop. That patient also presented with paraplegia. Okay, shall I go to the next case?
Yes, sir.
Yeah. This is a story of a 60-year-old man holding a tremor of both hands for the last 1 year. He noticed difficulty in walking for the last 6 months in the form of buckling of the knee. This walking difficulty gradually progressed to the extent of requiring support of a person to walk about for the last 2 months. No history of any paresthesia. History of perseverance and micturition for the last 1 month. That is on leading question. So go back to the history once again. Tremor of both hands for the last 1 year. Then difficulty in walking for the last 6 months in the form of buckling of the knee. This walking difficulty progressed to the extent of requiring support of a person for the last 2 months. No sensory complaint. Bladder problem on leading question. This is the examination of the patient. Case. പെട്ടെന്ന് നോക്കി ഇവിടെ നോക്ക് ഇവിടെ പെട്ടെന്ന് നോക്കണേ ഇവിടെ നോക്കി മോളിൽ നാക്ക് നീട്ടി ആന്ന് പറഞ്ഞ് ഇങ്ങനെ പെട്ടു Yes, got a postural tremor, not like a rest tremor of Parkinsonism. Tone was normal. Or also normal in the upper limb. Is no finger nose incoordination. Tone in the lower limb is normal. For examination, weakness of hip flexors bilaterally about 4 plus. A little more powerful on the left compared to the right. Knee extension about 4 plus. The hip abduction was normal. Adduction be weak on the left side, normal on the right side. Sorry, weak bilaterally. Hip extension was weak on the right side. Bilaterally weak, more weak on the right side. That is better on the left side. However, dorsiflexion, plantar flexion was normal. Plantar flexion was normal. Flexor longus was also normal. Flexor is normal in the upper limb. Decreased triceps on the left side. Dorsal flex just elicitable. Both knee and ankle jacks, knee jacks are just elicit, not reinforcement. Reinforcement, I could get a knee jack. There's a flicker of movement. Ankle jacks were absent. Plantar flexor. Sensations normal, except for the impairment in the distal part. For JPS sensation. Say all normal, there is no sensory level anywhere. He said he is able to feel vibration. There is decreased on the toes. Angle it is able to feel. The lower limb it is impaired. Made mistake. It's impaired. It also is impaired. Even with eyes open, he tend to stay to either side. With eye closed, there is no particular worsening with eye closure. He has walked this is the way he walked. He could walk on, could stand on heel, but mild weakness or right dorsiflexion. Toes, he can walk on toes very well. He could get up from the, even though he combines hip flexion, buckling, he could get up from the sitting, squatting position very well. This also was normal. So an examination, Kaylner's normal, motor, tone, normal toned upper and lower limb. Power all normal in the upper limbs. Lower limb weakness of both hip flexors bilaterally on examination lying down. Hip abduction normal. Adductors mild weakness on the right side. Hip extension weak on the right side, probably mild weakness on the left side as well. Normal power of quadriceps. Knee flexors normal. Both dorsiflexors, plantar flexors, EHL, FHL are normal. But he, on walking, he is not fully dorsiflexing on when he asked to stand on heel. Detail both upper limbs all just elicited. Or lower limb both knee jerks elicited with reinforcement. Ankle jerks were absent. Abdomen reflex bilaterally sluggish. Plantar both flexor. Chest pain normal. Vibration upper limb normal. Lower limb impaired in the right big toe. Normal in the left big toe. JPS impaired with both toes. Stance, attacks even with eyes open, tends to fall to the right side. Rhombus test not particularly bursts after closing the eyes. Gait, some ataxic gait. It could not walk on heel, but could walk on toes very well. Could get up from his too. Central and back neck. So, any clarifications you need, I can tell you.
Power, sir.
Power in the lower limb, on lying down, hip flexion hip flexion is weak. Right adduction was weak. Hip extension was weak. The left side, left hip flexion was weak. Both the lower distal muscles were normal. Knee jerk and ankle jerk, knee jerk just elicited after reinforcement, ankle jerk. It is a diabetic also. And sensory impaired vibrate joints over the toes only.
Right hip extension was involved, but hip abduction was normal, sir.
Now that's what I got. But that is correct. Whether you may not be cooperating very well. Now, this is how you find examination. No, sometimes when you see me examining, I coax him into I shout at him to do the muscle testing. But still, they may not. So always in lower limb, look for to find out the weakness of the muscles. Look for the activities like asking the patient stand on heels, stand on toes, get from squatting position, stand on one leg, tunnel back test. So that will give more idea rather than manual testing in the lower limb. These people may not cooperate when you lie down on the court. You have to go for objective evidence of weakness.
But sir, in examination, the examiners will not accept the patient not cooperative means.
Yeah, right. What is it? Yeah, correct. But this is real life, no? This is real life. See, when you saw me examine hip flexors, I got trying my heart, still I couldn't break it. Normally, hip flexors, one cannot break that hip flexor.
Yes, sir.
But he could get up easily from the sitting position, squatting position. So far, the muscle is weak, I do not know.
But what's the problem of having a normal abduction with weak knee? I mean,
that's against that, and nothing against. Only thing is against the radiculopathy. That's what she was trying to say. If it's a radiculopathy, you expect a hip abduction and the hip should be weak. Here it is like they have to think of something else other than radiculopathy.
No, hip abduction is usually L5 and the other one is S1, no? Mostly.
No, in fact, see, if you take the gluteus maximus, L5, S1, 2, the hip abduction also L5, S1, 2, L5, S1. So
abduction is more L5 and extension is more S1, no?
No, that would be difficult to say. Both are contributed by L5, S1.
But distally it is grade 5, sir.
Distally is grade 5.
Total duration is duration.
But duration
of the symptoms.
Just 1 minute. I myself have forgotten that thing. I shall tell you just now. 6 months.
It's a CADP variant.
Okay, could be a CADP variant. That's a good possibility. Okay, let us see. So we thought maybe an LMN lesion, no? Because postural muscles are more weak, reflexes are down, impaired vibration. Okay, so maybe CADP. Let us say element, that is the thing. So I can only say element weakness, whether it's CADP or a quad equina. It's difficult to say.
So diabetic. Patient is diabetic.
Diabetic also, plexopathy. That's the first possibility. I thought was plexopathy in this patient.
Diabetic hemorrhage.
That is my first, because that can put in, weakness can be confined only to the postural muscle. This can be expired. That is my first possibility, not cardiac. Then I secondly I considered.
Tremor, is it, does it favor a CADP tremor in the upper limb?
Tremor is totally unrelated. That is a venous essential tremor, which I had been having earlier. There is nothing to do with the percent problem. There's no weakness in the
Inclusion body myositis also, sir. Can it be?
inclusion body myositis, usually they affect the finger flexors in the upper. That's very characteristic thing is the long finger flexors in the upper should be affected. That's a characteristic thing. And cordyceps. The cordyceps is relatively spared, but affected is a hip flexion, what I will take out. As you said correctly, the cordyceps weakness. Pardon?
Lumps. Is it possible lumps?
Lumps, lumps is possible. There's a possibility there. Lambert is a possibility that can be ruled out. Yes, you can think of that thing. The neuropathy part, the sensory loss may be unrelated diabetic mellitus. That's not correct. There's also got a bladder involvement from the history. I mean, that's only a leading question, may not be correct, but there is a bladder. Everything is not fitting with, It's got something like a plexopathy. He has got a diabetic neuropathy, may be contributing to the part of the deficits. And he's got a main thing, seems walking difficulties out of proportion to his weakness. Don't you think so? Because he is able to get up, he can walk around and heal, but he is not able to. The sensory loss is already conveyed to the big toe, will not produce an ataxia at all, but he is still ataxic. Okay, pardon? Yeah?
Pain, back pain. Back pain.
No back pain, no back pain.
Clinically, what attacks is that, sir?
No, I see. I also cannot. He walks little broad base. You saw him walking. No, he's not. We cannot say whether he's ataxia. What to call it? I do not know. He's got imbalance while walking with a broad base. I'll show that video. Last part of the video.
That can be due to gluteal muscle weakness.
Yeah, maybe. But the problem is not having muscle weakness of getting him. I'll show that last part. He is standing like that. This is a walk, walking slow, slightly broad, not truly ataxic. I don't know what do you call this gait. But on stands, he is ataxic.
What's the usual reason for standing ataxia on stands with the eyes open?
He was all. That's the thing you observed in him. When eyes open, he was also going to one side. Is it a kind of postural imbalance? Maybe, I do not know. Maybe postural imbalance. But with the presence of proximal weakness, whatever I could get, patient can stay to one side because ultimately it must be strong to make you stand erect. Some disparity is there. He complained as buckling. That's why he came to me. For an examination, not much of a cortices weakness.
Would it be large fiber neuropathy alone, like a B12 deficiency or something, causing a severe possession?
The only thing is distal muscle is so normally preserved, only confined to the postural muscle. One should nearly consider plexopathy rather than a large fiber neuropathy.
If there is a weakness at all, is it due to the position sense impairment?
Yeah, but no, that is a good point. But what you observed was that even with eyes open is ataxic, but that ataxia is not particularly worsened by closure at all.
Is it psychogenic, sir? Because it's not.
Yeah, it could be psychogenic.
There's no corroboration clinically.
There is no corroboration, but is correct. There is no corroboration.
Did you check on one leg, sir? Getting up on one leg for cordyceps?
That I did not do because I should have done that to punch cordyceps. But he could easily get up. That means in the cordyceps, the patient not be able to do it like that.
Easily, how can he get up, sir, if he's so disabled? If he had got a buckling,
Yeah.
he'll be
Well,
fearing, you know.
No, that is the thing the patient presented to me with. So the history, verbatim, whatever told, what happened in this case which I present to you, that whatever he says, I write it down, my assistant will write it down. That I history presented to you. Okay. It's up to you
Maybe
to
that the weakness is in between fluctuating. In between, maybe it is more, so that is buckling.
correct.
So
Maybe
then
that yeah, right. Anyway, there is something, it's not fitting with anything. No, it may be neuropathy, maybe contributing, as if Joy was telling, maybe ataxia, either post-colon may be contributing. So let us see go for the investigation.
That might be favoring LEMS, sir. Just because one of the different diagnosis was LEMS.
LEMS, I think.
No, because of fluctuation. Just because of fluctuation, I was telling that.
Actually, not much of a fluctuation. The only thing is, see, this all happens every day in an exam. You know, someday you may be cooperating, someday you may not cooperate. That we don't tell it is a real fluctuation. No fluctuation from the history itself. Back to this. Okay, let us see go to the investigations. Let's see whether investigations can help us in this issue. Okay, what investigation you want?
Nerve conductions.
So nerve conduction, the peroneal amplitude is decreased bilaterally, but not much. It's got 4.2 and 3.8. TA pickup is good. And upper limb conduction is normal. Sensory potential are all normal. FA is also. So I expected some abnormality in the conduction, but it's not.
Ganglionic.
But femoral conduction, should it be done, sir?
Yeah, femoral. So I did a femoral conduction also. That's also normal. I did not show that.
H reflex.
H reflex I did not do because conduction is normal. So H reflex in what way is going to help us?
RNS.
But RNS, okay, I did not do that. I did an MRI. I did not do the RNS because myasthenia confined only to the. I mean, you mean to say the Eaton Lambert confined only to the lower limb? Okay, let us see. So, but I did not do that. So I did a lumbar spine MRI was done. And this is the dorsal spine, upper dorsal spine, T3, T4, T5 to D7. This is the cornus region. Then the caudate vena. Other test was done. So MRI normal, conduction almost normal. What do you want me to do?
Contrast.
Brain, sir.
MRI brain.
MRI brain, why for?
The ataxia. Because not correlated.
Okay.
NPH.
Okay. NBH, correct. So I did an MRI brain. This is the MRI.
Did you say urinary incontinence?
Yes, leading question was complaining of perseverance and mixture. So what is the diagnosis?
NPH.
NPH.
This is typical NPH and yeah, because this is the classical finding which make you suspect that patient is going to respond. Now, what are the findings? I'll tell you this particular patient. This is the window sign. See, that is one pocket of CSF sign. These are the window sign. Look at the adjoining cortex. Cortex is narrow, thickened. There is no space. That means there is indicating a normal pressure hydrocephalus. In NPH, the convexity will be narrow, but except for the CSF loculations will occur. So this is NPH. Now I'll tell you the classical findings in just 1 minute so that I'll make you understand. One is ventricular dilatation, everything about you know about all those things. Then the Evans index, sharpened callosal angle, and DESH. DESH is the one which is going to predict the good responsiveness for the shunt surgery or CSF time. That is disproportionately enlarged subarachnoid space. I will tell you what that is later on. What about Evans index? It's the index of estimation of ventricular volume. More than 0.3 is defined as ventriculomegaly. The other is callosal angle, the angle between the left and right parts of corpus callosum. More than 90 is said to be the cutoff value. How to measure and all I will skip. And this part, I am going to tell you detailed. That is, CSF volume gets significantly increased in the Selwyn fissures, but decreased in the superior convexity and medial subarachnoid space in addition to the ventriculomegaly. This includes tight high convexity, enlarged Selwyn fissure, and entrapped cortical sulci. These pockets of CSF accumulation indicate disruption of the CSF absorption. This is radiographic indicators. You find ventriculomegaly and the widened increased volume in the CSF fissure, but the tight high convexity. No space there. This may be mistaken for cortical atrophy, but they are not atrophy. This got hydrocephalus, and you find fluid pockets surrounded by tight sulci. Other sulci are tight, only some fluid pockets. Not a cortical atrophy, should be converted only 2-3 sulci alone. So this is not a cortical atrophy, they are fluid collections. These are markers of good responsiveness. Fluid tend to accumulate not only in the Selwyn fissure, but also in other major fissures like calcarine, peritoxypital, and logical fissures and connected sulci. They may be mistaken for atrophy or arachnoid cyst when viewed only in one of the 3 anatomical planes. This is again, you find the narrowing of the CSF space in the top. These are the widened Selwyn fissure and the CSF spaces. And this is NPH, tight convexity there, and convert to Alzheimer's disease if the convexity is not tight. Both have got a dilated Selwyn fissure, but the sulci are open in the top on the AD, whereas NPH it is tight. This is NPH need not always have this tight, this thing. Shows character to, this is the, again NPH with features of DESH, but not with the tight convexity. I think I'll skip on. Now look at our patient. This is a tight convexity. There is no sulci there, widened sulci, but you get the fluid pockets. Another fluid pocket, widened Selwyn fissure on the other side. So this patient has got NPH. Okay, this is how the patient pool does because the findings are more like an LMN. But it is why did MRI? Because of this precipitating cellulose, the gait pattern. Gait is abnormalities out of proportion to the objective findings in the weakness. That was the clue. Because he was ataxia. Why is ataxia with minimal sensory, without much weakness, is able to get up and stand on heel. Then I thought there may be something else causing it. That is why the MRI was done, and the brain was done.
Any memory impairment was this?
No memory impairment.
Is there any explanation for the buckling, sir? With the NPH?
Pardon?
The NPH, can it produce buckling NPH?
No, it cannot produce buckling. that is a very funny part of it. It will not produce buckling. It can produce imbalance, can produce attacks, can produce falls, can produce. It can produce, the patient can fall to one side. This patient also on standing, if falling to one side due to posterior imbalance. That can also all occur with NPH. But buckling cannot occur.
The plexopathy may be there, no additional plexopathy, but NCS is not.
Why it is not there? But objective examination is not there. He was complaining buckling, but he could get up easily and he could, on applying pressure, he could, I could not break his corticeps.
The poor cooperation may be due to NPH because of the frontal dysfunction.
That's correct. Because the vacillating attention is causing his, when you examine, he may not be attending to my commands.
So how to
CSF flow studies, does that help? Flow rate at the level of aqueduct?
So these and because I had given a class on this thing, the studies have shown none of these investigations, flow studies, other are got a reliability. None of them are reliable. The most reliable radiological finding is the test. Ventricular volume dilatation, callosal angle, all have got a pitfalls, false negative in positivity. The high reliability is only for the test, predicting a good responsiveness. So the point is that any person with a cavity pneumonia with the hydrocephalus, which cannot be explained due to other things, do a CSF tap and find out whether the patient is improving or not.
So could this be arrested hydrocephalus?
No, it's not arrested hydrocephalus. Patient is symptomatic. No, arrested hydrocephalus will be remain like that without any symptoms. There is one entity called arrested hydrocephalus subsequently become enlarged. That again produces cavity pneumonia.
Sir, lumbar drain,
You tap, sir,
sometimes
30
the
ml.
tap test is negative, so lumbar drain is advised. So,
Yeah, no. I'll
experience
see that
during lumbar.
lumbar drain as well as the CSF tap has got the almost equal value. More efficacious is lumbar drain. But that procedure is now almost abandoned because of we got to keep it for 3 days and the chance of CSF infection is very high. So nobody does that as a therapeutic test. You can do CSF tap, that is good enough. Theoretically, within
Single tap is enough for 3 taps. Sometimes 3 taps are done. Single tap is
I'll
enough.
tell you the reason. See, if you do a CSF tap and remove 30 cc of this thing, according to the normal rate of CSF production, within hours that CSF is replenished. Okay. So then why should the patient improve after 24 hours? Remain improved. CSF has come back. It is not that. It's not the only thing. There are many factors contributing to the improvement after CSF tap. See, if you do one tap alone, the patient will remain asymptomatic or much better prognosis for months together. On the other hand, so usually I do three tap for 3 days. The idea, we use a large bore needle so that the cells should go on leaking out, just like a thicker petrol should leaking out. And I can show you persons who has improved or remain improved for months, 8 to 9 months following the CSF tap. 3 times done, finished. And then patient will come to you only after 1 year or 6 months. Then again tell me, asking me to repeat tap again. They are not willing for a CSF shunt. Why these people remain improved for a long period of time, we don't know. There have been many postulates that what some people did, some amyloid like material is we are removing in the CSF. That is explanation. Some people are. This is given in the literature also. Why this is improvement remain for long, we do not know. Many other factors are operating.
Even if 30 ml is removed, you again repeat it, or if you're able to take out 30 ml or 30 to 50 ml, you stop it at that, or you go on doing the next 2 days also.
Next day also 30 to 40 cc. But third day sometimes you may not get, but maximum amount of CSF I do 40 cc in the first day, preferably 30 to 40. That 2-3 times sometimes you may not get that CSF. Whatever amount you get, take it out. But I will make sure that you put a large bore needle.
And were there instances where you didn't have a good diagnostic test and still you did VP shunt because the clinical history was so?
Yes, I can. Actually, I presented these 2 cases in that can be. I'll show that case next week. 2 cases I will show next week.
If the patient has a dramatic response with the first tap, do you repeat the second and third taps even then?
Actually, not required. No, not required. If you got a first tap as a dramatic, see, our idea is to find out whether this CSF tap is designed to find out the shunt responsiveness. But I can tell you that why I'm doing 3 days, because I want to remove as much as possible, so that they can send home without any problem. Even with 1 tap, some people do improve very well and can remain improve very well. But if you do 3 taps, it's more happy because more of CSF is out now. See, the test is designed for what? Planning a V patient. How many of your patients have agreed for a CSF V patient? Hardly none. 2, 3, except for 2, 3, or 4 or 5. Well, many of them do not agree for a V patient. And we are also not very happy keeping any.
Any role for acetosol that some patients cannot be willing for surgery?
Absolutely no role. To my experience, absolutely no role. None of them have ever included the diagrams.
Wait. Sir.
Yes.
Sir, dilatation of the sulci is there, sir. The sulci will dilate. What is this tight convexity mean, sir?
No, this means there's iron in the pockets of CSF collection. The sulci, some of the sulci will dilate, but the other sulci will not dilate. That pockets are the one we call the dish.
Okay.
And that's called fluid pocket. I'll show that fluid pocket. Just 1 minute.
So that occurs only in the superolateral surface, is it? Or it can be down below also?
It can be, this is a Sylvian fissure that can be dilated. Even some of the cortex also, some of the sulci may be dilated. That's what is not dilated, the convexity and the supramedial surface. Superolateral surface. So this one, this one. Do you see this one? This looks like a dilated sulci. This is actually the pockets.
Okay, sir. Okay.
Then I
So
will show
does
one
that
more
mean
picture.
that this that area, the arachnoid granulations, is not taking up the CSF? Is because of that?
Maybe.
It's all-time high.
Yeah, that is the area where it's a functional block of the CSF absorption. That is why it is there.
Yes,
Tight.
okay.
This correct tight.
Thank you.
Okay, then. Okay, we'll stop solving it. So next week I'll show case of NPS. One more thing I wanted to show you, but is that thing, the question which came up now. Anyway, that also I'll bring to next week.
Thank you, sir.
Good night. Good night.
Good night, sir.
Good night.